I'm Dr. Sharda Jain. Today I'm going to speak about simple approach to diagnosis of a breast lump. Why it is important? It is important because the incidence of breast cancer is increasing, and every lady doctor, especially the gynecologist, should know how to approach a breast lump. Whenever there is a palpable mass in ovarian breast, everybody should think, the public should think, the family should think it is a serious lesion. All palpable lesions require evaluation, urgent evaluation. And now the triple assessment is a very effective strategy in the diagnosis of breast lumps. The first step is reach the doctor, confirm the presence of discrete mass. Next step, which the doctor has to make up the mind, distinguish between simple cyst from a solid lesion. The risk of breast cancer increases with age. The median age of breast cancer is 60 years. 95% of all breast cancers are seen in over 40 years. But we have seen breast cancer occurring in a girl of 19 years, 23 years, 24 years. So any breast lump is a suspicious. Majority of the breast cancers are sporadic. By this I mean in patients without family history of breast cancer, also the breast cancer occur. The first degree relative with premenopausal breast cancer becomes a very, very high risk factor. The causes are very many, but the palpable mass is seen in nearly 25% of the lesions. What is this triple assessment? Triple assessment has become the gold standard. It means examination by the doctor, and that's called clinical assessment, then use of imaging, and tissue biopsy for confirmation. If you use all these three things together, you can from the history is very important. Your age is important, personal history of breast cancer, past history of breast biopsy, family history of breast cancer in the first degree relative, history of trauma to the breast, any recent pregnancy or lactation. When you come and see, the physical examination is very, very important. This alone cannot definitely establish a mass as a benign or malignant. You require additional imaging as well as biopsy. Whenever the mass is irregular, fixed, it becomes suspicious of cancer. Malignant lesions, you find the skin is thickened and you have an orange cover, orange peel appearance. This is called pudy orange. There can be nipple discharge as well. Complete bilateral breast examination is very important to see the variation in the breast size, dimpling or retraction of the skin, nipple inversion or excoriation. Sometimes, if it's neglected, there can be fungating mass. I have known an IS officer where the breast lump had maggots. So you can see such a decorated person can do a self-neglect to that kind. Diagnostic accuracy of the physical examination varies from 60 to 85%. Patient positioning is very important. The arms must go above the head. The hands on the hips and squeeze inwards, flexing the pectoral muscles, the chest wall involvement one can know. The lymph nodes, axillary, cervical, supraclavicular, infraclavicular fossa should be evaluated for lymph nodes. Proper examination occurs with the patient both seated upright and lying position. At times, masses can often be appreciated more in one position than in another position. say the mass is benign, if there are no skin changes, it's a smooth and a mobile mass, it's soft to firm to palpation, and it has well-defined margins. You suspect cancer if you find the mass is hard and immobile, maybe fixed to surrounding structures, and a poorly defined or irregular margins. And sometimes you can find infection, then there will be classical features of inflammation. In imaging, mammography stands and has got a name by itself. Whenever there is a mass, it's beneficial in finding occult cancers. So any woman more than 30 years or older with a breast lump, mammography is suggested. Spot compression views and a magnification views are recommended. Multifocal or multicentric disease is sometimes there, and it will be noted very clearly here. Now, when you see the mammography, the reporting system is called BIRAD. BIRAD 0 category needs more information and further imaging studies are required. If it comes as normal, benign, and probably benign, the follow-up is required with ultrasounds. If there is a highly suspicious, the biopsy is needed. If malignancy you suspect, then a biopsy. The fifth is malignancy suspected and the biopsy confirmation. Information by biopsy. If it's a known cancer, you already know that you're treating for malignancy. So BIRAD 1 and 3 should be followed with regular ultrasounds. Score 4 and 5 requires a tissue biopsy without any delay. Palpable mass, negative. Imaging study, surgical. If you do not find anything in mammography, surgical removal is important. Score 6 is given only after the biopsy is cancerous. Ultrasound of the breast. Whenever you have a lump and a woman ages less than 30 years, in that case, the ultrasound is required. To know the density of the breast tissue in a younger woman limits the sensitivity of the mammography. The false negative rate is as much as 50%, and in patients who are less than 35 years of old, with a palpable malignant breast mass. Ultrasound may identify simple or complex cyst architecture. So, when you do an ultrasound, you can come to know very clearly whether it's a cystic or a solid mass. Cystic mass can be simple or complex. Simple cyst, if it occurs to you, aspirate and then confirm. Complex requires a biopsy. Solid, if it's suspicious, take a biopsy. Probably benign. Again, biopsy will be much better to rule out things. Now, here we should be very clear. There is a lot of myth in people's mind, in doctors' mind, in nurses' mind. There are three things. A, fine needle aspiration cytology. Till about 4 or 5 years, this was the only thing which was used. And in 90% of cases, you could find whether it is malignant or not. But it was unable to evaluate histologically. Now the science had advanced quite a bit, and you require histological diagnosis as well as molecular hormonal diagnosis as well. So in that particular case, it is easy, office-based procedure, very small needle. If it's positive, it's okay. If it is negative, further confirmation is required by a core needle biopsy or by excisional biopsy. This is very important information and should reach everybody. FNAC negative does not mean anything. It only means you require further evaluation. Core needle biopsy is the thing which is done these days. It is easy to do it. It's a relatively painless procedure. It's an office procedure. A standard histopathology can be done in the tissue removed by it. It is a slightly larger needle, but it is an office-based procedure. If this is also negative, then excisional biopsy is required to do standard histopathology. It requires surgical procedure, so it requires an operation theater, a large incision is required, and naturally incision is related to whatever is size of incision, it will be painful accordingly. So I think, you should be very, very clear about these three diagnoses. Fine needle biopsy, you require a 22 to 26 gauge needle, and it can be very simply done. It can be also used for lymph nodes, whether they are reactive problem is there or there is evidence of malignancy. Core needle biopsy, this gauge needle is 8 to 4. It is their histopathology diagnosis can be made on it. It is always good if it is ultrasound guidance is there. Excisional biopsy is removing the entire breast mass, and it is an accurate histological diagnosis. This is only to be done when your core biopsy is negative. So with this, I think each one of you must be very clear what is the approach for a breast lump. Every lady doctor should know it, because majority of the ladies in India approach the lady doctor. Whether you're MBBS, whether you're a gynecologist, or whether you are a surgeon, you should know exactly what needs to be done.